Good evening, everyone. Again, we are back with another session in the masterclass. Today, we have a case presentation, and to moderate this and to take it forward, we have senior examiners. We have Dr. G.V. Chowdary sir, who is a senior consultant neurologist and clinical director, Department of Neurology at Yashoda Hospital, High-Tech City, who brings us expertise from the neurology perspective. And to add to this combination, we have Dr. J.S.K. Chaitanya, who is head of the department critical care at KIMS Hospital, Sketchboli, who is passionate about neurocritical care. So we can see both the spectrum of neurologist and neurointensivist coming together to take this case actually. And to present this case, we have Dr. Komali, who is a student at critical care medicine at Yashoda Hospital, High-Tech City, and Dr. Ranga Bharadwaj, who is the IFCCM student at Yashoda Hospital, High-Tech City. Thank you for joining us, both the examiner Subbaiah sir and Dr. JSK Chaitanya. And over to you, Dr. Komali and Dr. Ranga Bharadwaj, for your case presentation.
Good evening, Chowdary sir, and good evening, Chaitanya sir.
Yes.
Good evening, Ravi sir. Good evening, Venkatraman sir. Today I am going to present a case. 49-year-old male came with a chief complaint of on day 1 he presented with altered sensorium, irrelevant speech, and aggressive behavior. Later, speech reduced to incomprehensive sounds. On day 2, he became drowsy and not responding to speech and not able to take feeds orally. And on complaining of one episode of seizure-like activity with a staring look and stiffness, lasted for 1 minute and did not regain consciousness after that. And they came to our ER department with a past history. He is a known case of CKD on maintenance hemodialysis thrice weekly, which last dialysis was done 2 days earlier. Due for a dialysis on the day of admission, he had a left AV fistula through which dialysis was done. All ischemic stroke was there, no residual deficits. He is on aspirin tablet and with a past history of diabetes mellitus, hypertension, hypothyroidism, and he had a right thigh chronic ulcer. Currently, he was on ceftazidime avibactam 2.5 grams IV 8th. He used that drug for 21 days. And personal history, he was on his mixed diet, normal bowel and bladder movements, normal sleep pattern, and no addiction. And family history, nil significant. On examination at ER, vitals, pulse rate was 108 per minute, regular in rhythm, and non-invasive blood pressure monitoring 150 by 80 mmHg with a respiratory rate of 22 per minute, with a saturation of 94% at room air, and with a GRBS of 145 milligram per deciliter, and temperature was 98.3 degrees Fahrenheit, no pala, no icterus, no cyanosis, no clubbing, and bilateral lower limb pitting, mild pitting type of edema was present. And neurological examination, patient was drowsy, not arousable, opening eyes and moving limbs to deep painful stimulus and making incomprehensive sounds and gurgling noise from the throat with a GCS of E2VT M5 and pupils 2 mm left and 2 mm right, reacting to light. Neck stiffness present, tone and power could not be examined as the patient was not cooperative, and pooling of oral secretions present. And respiratory system examination, bilateral normal vesicular breath sounds present, noisy breathing and gurgling sounds present, and cardiovascular system S1, S2 heard, no murmurs appreciated, and per abdomen examination, soft, non-tender, and bowel sounds present. Based on the clinical history and past history and clinical examination, my differential diagnosis were seizure.
Would you like to summarize at this point once?
Yes,
Based
sir.
on history and
49-year-old male presented with altered sensorium and reduces speech to incomprehensive sounds and drowsiness, and he had one episode of seizure, sir, and with a background history of CKD on maintenance hemodialysis with hypertension, and old history of CVA is there, sir, and hypothyroidism is there. And on examination, his GCS was E2V2 M5 and irritable, drowsy, with
when you
pupils.
said M4 response,
Yes, sir.
you could also try to tell if there is any asymmetry in movements.
No asymmetry, sir.
Okay.
And neck stiffness is present, sir. And pooling of secretions is there, sir.
Okay.
Based on my history, past history and clinical examination findings, I am suspecting my differential diagnosis were first is seizures, and second is meningoencephalitis, and third one is cerebrovascular accident. Fourth one is metabolic encephalopathy. Fifth one is septic encephalopathy, and sixth one is ceftazidime-induced CNS toxicity, sir. Seizures, maybe he had one episode of seizure followed by drowsiness. So I'm suspecting he is in a post-ictal confusion and ongoing seizure. Meningoencephalitis, he is having altered sensorium and seizure-like activity followed by neck stiffness is there. And cerebrovascular accident, he is a known case of CKD. And with the old history of CVS also there, so we are suspecting recurrent CVS. And metabolic encephalopathy, he is a known case of CKD, can be uremic encephalopathy or electrolyte disturbances. And septic encephalopathy, because he is having a non-healing ulcer. So the source may be the right thigh, sir. And ceftazidime-induced CNS toxicity, because he used ceftazidime 2.5 gram 8 hourly for 21 days. So we suspected ceftazidime-induced CNS toxicity also, sir.
Okay. So, how would you manage now? I mean, what would be your first step? You have a big list now. See, this case, like according to what you presented, I think you should to tell how it started and how it progressed here. So this patient started with encephalopathy.
Altered sensorium.
Started with having an encephalopathy and then progressed to have a seizure by the time he presented to you.
Yes, sir.
So as you said in your list, for a CVA, presentation over period of 3 days, it's less likely, right?
Yes, sir.
CVA usually present in an acute
Suddenly
presentation. Here it is like a subacute. I mean, the illness as such. It started with encephalopathy and then progressed to a seizure.
Yes, sir.
So I think the rest would come up. Metabolic encephalopathy or your drug-induced toxicity, these might come up.
Yes.
And CVA, that's why I asked you if you could present some paucity or asymmetry, like pupillar asymmetry, or when you say M4 response, if you have showed some paucity in movements in one side, then again to substantiate a CVA, it would have been useful. So CVA can go down, and I think you need to bring the rest up. Meningoencephalitis is still a possibility because he's already has some infective focus somewhere. Somebody frequenting to hospital for dialysis and all should have been having catheters. So encephalitis we definitely can't rule out here. And metabolic and septic encephalopathy also will fall into that. Yeah. Okay. How do you want to proceed now on? First thing, what you would like to do?
First thing, I would like to check the GRBS and saturation, sir, ABG. As he is having threatened airway, I would like to proceed with intubation, sir. It can be a hypoglycemic episode and hypoxic episode, so we have to rule out first, sir. And based on ABG, we have to proceed as there is a gurgling sound and drowsiness, chances of aspiration and is there. So I would like to proceed with intubation, sir.
Okay.
And stabilization.
Okay.
So what are the cause of neck stiffness in this case you can consider?
Can be a meningoencephalitis cause, meningitis.
What are other causes of neck stiffness?
In subarachnoid hemorrhage, we can get.
Any drugs can cause? Sometimes antipsychotics also can cause this neck movement restriction. So you have to be careful in this type of cases. So what possible seizure you think in this type of setting, background? What is the entity called? Suppose the patient is in status. So what status you would consider?
Status epileptic.
Apparently there is seizure, no?
Non-convulsive status epilepticus.
Yes.
With
So
this given background of CKD, is there any other encephalopathy which is a known entity which usually in this group of patients?
Uremic encephalopathy and
high blood pressures.
Press syndrome, sir.
Press
Posterior
syndrome. That
vesicle.
also could come in your differentials.
Okay, sir.
Yeah. Okay.
On day 1 at ER, due to low GCS and pooling of oral secretion, family were counseled regarding need of intubation for airway protection and further evaluation. The family has not consented at that time for intubation, and initial ABG was done, which shows metabolic acidosis with respiratory acidosis with a lactate of 2.6 and glucose 162, and anion gap was 8.2. At ER, injection levetiracetam 1 gram IV stat and injection meropenem 2 grams IV stat was given, and patient was shifted to ICU for further management. On receiving to ICU, his sensorium was low, GCS was E2VT M5, and gurgling sounds were present. Family was counseled again and took consent and proceeded with intubation, followed by mechanical ventilatory support. And MRA brain with IV contrast was done, which shows focal area of gliosis with mild volume loss seen involving the right superior frontal gyrus and chronic infarct sequelae. Treatment at the time administered were injection meropenem 1 gram IV 24th hourly, injection ticoplanin 400 mg IV 12th hourly for 3 doses, followed by 200 mg 24th hourly, injection levetiracetam 500 mg IV 12th hourly, injection pantoprazole 40 mg IV 24th hourly, tap thyroxine 50 mcg orally 24th hourly. An EEG was done, which shows generalized synchronized periodic sharp wave activity 2.5 to 3 Hz per second, lasting for more than 10 minutes, suggestive of non-convulsive status epilepticus. And lacosamide loading dose was given 400 mg stat, and continued with 200 mg IV 12th hourly, and started on midazolam infusion with continuous EEG monitoring. And initial laboratory investigation showed anemia with WBC count within normal limits and low platelet count, and creatinine 6.17, and electrolytes within normal limits. Total bilirubin was 1.45. Remaining investigations were within normal limits, and TSH was 2.56 with the calcium 10 and phosphorus 2.8. And he was due on there was a due for dialysis. One session of dialysis was done.
Okay. So if you go to the first slide, I think you have chosen to do MRI at that time.
Yes, sir.
See, we have a challenge that initially airway was not secured.
Yes, sir.
Yeah, in that case, would you still, I mean, if the family has not consented yet, would you still have gone for MRI or would you have done a CT?
CT, sir.
Okay. Now that airway is there, now you chosen MRI.
MRI,
So
sir.
what is the additional, what are you looking for in MRI?
If
In
there
this
is any
case,
meningeal enhancement, is there any stroke?
See, we have this patient who is presenting with 3 days history.
Yes, sir.
Yeah. So what is that you're looking, I mean, why you have chosen MRI here? And
Meningeal enhancement will be present in MRI, sir. So to rule out meningitis.
Okay. And you have chosen to give to do a contrast study. How safe it is in a patient with CKD and how safe it is in patients with hemodialysis. Contrast, MRI contrast.
He is on maintenance hemodialysis, sir, so that's why we proceeded with the contrast.
Okay. Now, is it safe?
Yes, sir.
Yeah, the newly available MRI contrast, gadolinium contrast, it is still safe, but you should immediately schedule a dialysis. This is specific for MRI contrast. CT contrast is not relevant to do immediate dialysis, but in MR contrast, immediate dialysis can help off to take the contrast out. And second thing, the fear of volume overload and all is not common. I mean, you have to hydrate before and all is not required in doing MRI contrasts. That's one thing. So as you are suspecting encephalitis, you wanted to look for meningeal enhancement. Okay. If MRI was not feasible at the time, even CT is not feasible, would you go ahead with your CSF analysis here?
Yes, sir.
Okay. You should have looked at pupil.
Pupil papillary edema to rule out
Because we have a low
infections.
GCS, no? So
Yes, sir.
that's one thing you should have done before you proceed for CSF. That's one thing I wanted you to add on. Okay. And with the drugs you have chosen, first is anti-epileptic. Second, antibiotics.
Okay, sir.
What else could have been done here? You have chosen meropenem, 1 gram 24th hourly.
Yes, sir.
Here you have your differentials as meningoencephalitis
Yes,
as well. And would that dose be sufficient?
In CKD cases, normal cases, we can go up to 2 gram IV 8th hourly, sir, but he is a CKD on maintenance hemodialysis. So 0.5 mg is required, sir, but for CSF penetration, we have given 1 gram, sir.
Okay. Teicoplanin?
He is having right thigh ulcer. For a soft tissue infection to cover the thing, we have added teicoplanin, sir.
But if you have to cover meningitis?
Vancomycin, sir.
Vancomycin should have been preferred till your diagnosis is over. Okay. Next, anti-epileptics?
Levetiracetam.
Okay. Is that a good choice here?
Yes, sir.
So if at all, what you have to do in the case of CKD on dialysis? Yeah, levetiracetam you can give, but what
After
precaution?
dialysis, we have to give the dose, sir.
Yes.
How much you should give?
Normal, increase the dose. We have to, because 50% of the drug will be dialyzed in the hemodialysis, so we have to increase the dose.
Yeah, post dialysis you can give 50% of the dose.
Yes. So especially in CKD or patients who are undergoing dialysis, if you have an option, you can prefer drugs which don't accumulate, which are mainly renally excreted. If it is a CKD patient, you should choose other drugs which are not renally eliminated or somebody which are metabolized with through the liver. The other thing, if they are on dialysis, we should choose drugs which are less filtered by dialysis because that fluctuations will be very high. The trough levels might not maintain. So those fluxes you should reduce. So you can consider preferring drugs which are not filtered through the membrane. Okay. Okay.
CSF analysis was done. The appearance is clear with the WBC cells count of 2 cells, polymorphonuclear cells 35% and lymphocytes 65%, with the sugar 72 milligram per deciliter. CSF to blood sugar ratio was 0.6 and protein 90 milligram per deciliter and chloride 126 milliequivalents per liter and ADA 2.91. PCR meningitis panel report was negative and gram stain no organism detected and gene expert MTB was not detected, sir.
Okay. Now have you ruled out infection?
Yes, sir.
Okay. Protein is high.
It can be other non-infectious causes
Like?
Autoimmune encephalitis and malignancy.
Okay. Autoimmune, paraneoplastic, or sometimes even somebody like this patient who is in status, no? Even post prolonged seizures also you can find this elevated protein.
Still you feel that this patient can be there still infection? Even the cells are not elevated. Yeah, you have to always keep the option that infection still could be a possibility. Sometimes immunosuppression patients, especially viral encephalitis and all, they did not show initial elevation of cells. You have to always, you should not be very concrete, especially critical care specialists. You should be always have a suspicion that still a possibility. Unless because still the protein is elevated. Okay, suppose for this case protein is elevated. What other conditions you can think in these cases?
Partially treated meningitis.
Partial treated meningitis cells should be there, no? What else you have to think in terms of these cases?
Traumatic.
Suppose forget about seizure. This patient was brought in altered sensorium. He was found to be having hypoxia. He is not able to move the limbs. Many times we get misled, no? Patient will present in quadriparesis not I mean hypoventilation. So what do you think of this type of cases?
Anoxic.
Yeah. Can you think of GB syndrome like?
Yes.
You should always keep that also a possibility. Maybe we are getting biased. 5 minutes. So you have to think in terms of any GB syndrome. What other conditions you can have protein elevation with normal CSF?
Any subarachnoid hemorrhage.
Yes. And even carcinomatosis meningitis also you can have sometimes. Yes, good. You can proceed. Yes. Because the only thing, the point highlighting is always in this type of setting of these patients, sometimes we burn our fingers thinking that initial CSF is normal and there is no infection. Right. Yeah.
On day 2 to day 3, patient was on mechanical ventilation. Continuous EEG was connected to the patient for 12 hours, which showed alpha to theta altering pattern suggestive of cycling alternating pattern encephalopathy with intermittent triphasic discharges with anterior to posterior lag. Serial EEG showed no further epileptiform discharges. Hence, gradual midazolam infusion tapered at 1 mg every 12th hourly from initial 6 mg per hour. Blood culture reports and tissue culture reports from the wound were negative. On day 4, patient is still drowsy, not arousable, and slightly moving to deep painful stimulus. And patient was on mechanical ventilation with FiO2 of 30%. Further session of dialysis done as per requirement. And repeat EEG show epileptic discharges. Started on midazolam infusion and was tapered as per continuous EEG. And MRA brain epilepsy protocol was done. It is suggestive of diffuse sulcal flare hyperintensities. So because of persistent seizure activity and previous CSF showed mild elevation in proteins, we would like to repeat the CSF, sir. We have done CSF repeat analysis. It showed 5 cells, 50% neutrophils and 50% lymphocytes. With this time, the proteins elevated from 90 to 119, sir.
So here, when you started with the EEG patient,
Yes.
you had a non-convulsive status epilepticus pattern, and you have chosen 2 IV drugs and 1 infusion drug.
Yes, sir.
Okay, now how did you titrate the dose, and what were your targets of treatment then?
We have to achieve burst suppression, sir. We have to maintain at the dose for 24 hours. Gradually, we have to reduce 20% every 6 to 12 hourly.
Okay, so now what do you mean by burst suppression? What is your target?
Decreased activity of
about the seizure activity and then try to prevent its progression.
Okay, target are you should have 1 to 2 second bursts with at least 10 seconds of burst interburst intervals. And if this pattern you are able to sustain with your treatment regimen for 24 hours, that is adequate burst suppression, and beyond 24 hours you can start tapering your drugs. Okay, then how would you know that you are again going in your patient? Because once you tapered, patient again had seizures. Now this means patients by definition will move from
Refractory.
status to refractory. What could have been the causes here in this patient?
can be one autoimmune we can suspect, sir. And there
First is like etiology. We didn't know the etiology, or etiology is uncertain, or maybe the treatment to the primary cause is not addressed yet. Okay, second, anything to do with the drugs?
dosage because he's on dialysis.
Yes. So because he's on dialysis, and the 2 drugs we selected, both are filterable.
Filtered.
We had one levetiracetam and lacosamide also. Both of them would require post-dialysis doses. So that flux would have caused. Okay.
So do you think that always burst suppression should be there? And suppose if the patient is well controlled, do you think that burst suppression should be always there? It need not be always, because Still that controversy is going on. Some people, initially they used to say burst suppression, but later they say if it is well controlled, you need not have burst suppression. The reason is some studies show that burst suppression patients had a high mortality comparatively.
Burst suppression per se is a poor prognostic sign, but as a target for treatment, it is used. That doesn't mean it's a good sign.
Okay.
And I think in your slide, in the second day, you mentioned that there is cyclical alternating
Alternating
pattern
pattern.
encephalopathy. So what is that saying?
Awakening.
Good sign or bad sign?
Awakening is the alpha.
Okay. Can we consider that also to be a seizure or a part of status?
Spikes are not there. Triphasic is there.
If not for this patient, if you see the same pattern in somebody,
Awakening.
it is a change in physiological state. Could be arousal, could be change in motor movements, it could be anything. So it's just a change in physiological state. That doesn't warrant treatment like seizures. It's still an encephalopathy, but not a status stage. So here, if patient from status is moving on to this, it's a good sign. And usually prognosis is good in such patients. Mostly causes would be metabolic here in such cases. Okay.
In critical care patients, when you ask for bedside EEG,
When there is a critical heal, when seizure activity which is not returning to the baseline, lasting for more than 10 minutes, and any post cardiac arrest or EEG showing within 30 minutes epileptic form discharges, or any intracerebral hemorrhage with subarachnoid hemorrhage or traumatic brain injury, or suspecting non-convulsive status epilepticus.
Where your encephalopathy is not explained by images, or when you have more suspicion whether it is structural cause or a metabolic cause, sometimes toxic cause. All these cases, EEG will help.
in the first slide, you had septicemia, no? Do you
Yes,
think
sir.
that could be the cause of status?
It can decrease the threshold, sir, so can trigger
Which drug has the highest potential amongst
Epiphyme,
you
Cefepime.
might have seen in the that's important thing. Okay.
But ceftazidime also in this dose in renal failure definitely has very high toxicity. Like, I mean, how they present with encephalopathy and then non-convulsive status is very much a possibility in this case.
Okay, now the patient is in status, refractory status or supra-refractory status?
Refractory.
Status.
Okay.
On day 5, patient was on mechanical ventilation, occasional eye opening and subtle motor movements to verbal commands with a GCS of E3VT M5, and etiological evaluation is ongoing. PET-CT whole body was done, suggestive of autoimmune encephalitis. So we have sent the CSF for autoimmune panel and reports were awaited, sir.
So what is ruled out and what is still in evaluation here in this patient? What are the possibilities that can still there?
Infection is in the initial in the CSF pulmonary meningitis panel. Infection is ruled out, sir. TB is ruled out, sir. Gene expert is CVA is ruled out, sir. And autoimmune encephalitis is still pending, and
Autoimmune, paraneoplastic,
paraneoplastic
syndrome,
and drug-induced.
Drug-induced.
So these three are still ongoing.
Yes, sir.
Now your status is set.
Please go ahead, Chaitanya. Dr. Chaitanya.
Yes. So status epilepticus seems to be addressed, and there is EEG improvement in EEG as well, and clinically also. Sir, you would like to ask?
Yeah. So suppose if okay. So is it autoimmune encephalitis? Did they tell you that it is patient is having autoimmune encephalitis?
Based on PET-CT reports and remaining investigations are negative, so we are suspecting autoimmune, sir, and he is having recurrent seizure episodes. So we want to evaluate whether it is the primary cause.
The patient is improving or not improving? It's following commands or not?
Improving, sir. Mildly obeying minimal, simple commands, sir.
Okay. Fine. So you told patient is in refractory status or
Yes.
super-refractory status?
Refractory, sir.
When you then patient is on midazolam infusion, then how do you say it is refractory status? What is the difference between refractory and supra-refractory?
Refractory status when the status epilepticus continue to occur even after two anti-epileptic drugs. One of them is benzodiazepines. Super refractory if the patient is continues to have a seizure activity even after anesthetic drugs and more than 24 hours.
Patient is on midazolam infusion, no?
It's a benzodiazepine. We
Then
haven't added any other anesthetic agents.
that is midazolam IV
Even
infusion.
midazolam is
Yes,
considered an IV infusion drug.
It's an IV infusion, no? So what might have happened? So I partially agree. It could be a still refractory status. So technically, because I know about the case, so we should not have a biased URI. So what can happen? Suppose if you didn't supplement the drug after the dialysis, if the patient is having seizures, maybe still we can think in terms of refractory status. Probably, I'm just telling you possibility. Just increasing our horizon of thinking, right? So technically, if somebody says that the patient is on IV anesthetic agent, so you have to call it as a super-refractory status epilepticus. Fine.
Yes.
So did you exclude sepsis in this case?
Blood culture and tissue culture were negative, so we have sent that for culture and sensitivity, but no growth was detected in the blood and urine tissue culture, sir.
Okay. So now we are all in the corporate sector. We are giving high-end medication. Suppose if your examiner is from somewhere from the still good institutes where still they use conventional anti-epileptic drugs. What other anti-epileptic drugs usually initially they use after the midazolam or lorazepam or diazepam, whatever this one drug.
Phenytoin and phosphate.
So phenytoin, yeah. So when you avoid phenytoin, in this case, because now you have come to the stage. Now we are given levetiracetam. Suppose somebody presents phenytoin. So what precautions? Suppose you are working in a peripheral center where you have to give phenytoin. Now it is
We are not
available
supposed to give
legally.
any other drugs along with that, sir, because crystallization will be there.
No,
And
not like that. So in this case, suppose if you have a phenytoin is there, you don't have levetiracetam, will you give it? Will you give it or not give it?
we will give it, sir.
Yeah. Suppose which conditions usually you don't give phenytoin in this type of patients? What two things you have to observe in these cases? So this is the basic fundamental thing because it can have cardiac depressant action.
Yes,
And also it can produce hypotension.
yes,
So why it will have cardiac depressant action?
Mechanism.
So it acts through sodium channels, right? It is like an antiarrhythmic drug. So it can have cardiac depressant action. So why it can have hypotension? What is the constituent it contains? Phenytoin?
Propylene glycol.
Yeah, propylene glycol. When it contains, what it causes? It causes vasodilatation. So that can, and also it's an irritant, vein irritant also. So that's why you cannot give IM, you have to give only IV. So that's the reason phosphonatine was brought. But still when there is cardiac depressant, phosphonatine also will have cardiac depressant because it also acts on the sodium channels. Okay, now what other drugs you cannot give if the patient have cardiac problems? Because you are not a neuro resident, no, neurocritical care resident, you are a critical care resident. So you should know which conditions, which drug should not be given.
Ketamine to be
This
avoided.
is a teaching session. This is not a testing session. Please try to understand. So which drug you consider? Suppose if this patient has cardiac depressant, so cardiac problem.
Lacosamide can cause AV block and hypertension, bradycardia will be there, sir.
No. It doesn't cause hypotension. It has AV block
AV
tendency.
block.
Suppose if the hypotension is there, if the cardiac failure is there, you can use lacosamide. Only thing is if there is any
AV.
Those
PR interval
the prolonged, you are not supposed to give laxament. But levetiracetam is the drug of choice in this type of settings. What other drug you can give in this type of settings? Suppose if the patient has cardiac depressant action, what drugs you prefer? Levetiracetam, good. You can give lacosamide. But only thing is, as you said, you have to observe the interval prolongations. Then phenobarbital also can be given. Why phenobarbital? Does it cause hypotension? Yes, it also can cause, but it acts through how it acts. It doesn't have. It may cause direct cardiac, but why it acts through? How it causes cardiac depression through central. By reducing sympathetic tone, it can produce. It doesn't have antiarrhythmic effect like sodium channel blocker. It's not a sodium channel blocker. How it acts? It acts through
GABA.
So that's the reason it acts on the center. And by reducing sympathetic tone, it can produce hypotension. But phenytoin has more. So phenytoin, suppose you have, in which solution you dilute if you have phenytoin?
NS.
You should dilute only in NS. Why?
Crystallization will be there.
With dextrose solution.
Dextrose.
So what is the this one? Phenobarbital. What is the base of phenobarbital? It also contains propylene glycol only. But still you can give sometimes in 5% dextrose also, but not strictly. Why? So read that one also. So these things you should be more aware than neurologists, because okay, why phenytoin should be never given in 5% dextrose. Phenobarbital may be given in 5% dextrose in normal saline. A patient in shock, do you give what drug you avoid? A patient is in shock. Okay, forget about phenytoin. What are the drug? If the patient is having some hemodynamic instability with mild cardiac impairment, mild liver impairment, I gave the clue. Sodium valproate you should avoid, because it also has a cardiac effects and peripheral vasodilation. So for each drug, you should know the most important contraindication. I mean, these are not absolute contraindications.
Side effects. What to monitor, you should know.
You should know this one. Okay, so now levetiracetam, the advantage of these things are there. It is quite safe. Anybody can give, but still you should know. Suppose if you don't have that drug, if you have other drug, so you should know. Suppose you are in a war, you should not you search for the weapon. No, whatever weapon is there, you should use it. Like that only in ICU you have to use the medication, right? Yeah, please go ahead. I think I took a lot of time. Yeah, please go ahead. Please continue, Dr. Chaitanya. Sorry. Yeah.
So as you said, lacosamide and levetiracetam, you know any recent trial drugs regarding anti-epileptic drugs?
ESET trials.
ESET trial, yeah. So what is the other drug?
Phenytoin, valproate, and
Valproate, yeah.
levetiracetam.
Here you could have used valproate.
Yes.
Yeah.
Yes, sir.
Yes, because
What
that
is the
again
problem you get with valproate in renal failure patients? In renal failure patients, these are all simple entrance questions. They are not big questions.
Ammonia, hyperammonia with sodium alcohol.
But the patient is on dialysis, no?
Yes, sir.
So ammonia, whatever it is there, it will be washed off in the dialysis, no, usually.
Yes.
Pancreatitis,
Pancreatitis, hepatotoxicity, and thrombocytopenia is associated with
pancreatitis is sometimes you have to be careful in a case of renal failure when you are giving
sodium.
Valproate without causing hepatotoxicity also can cause hyperammonemia. That we need to be cautious. Somebody you initiate and then they develop encephalopathy, don't just look at LFT and how to see ammonia as well. And in infusions, you have chosen midazolam. What else can be used, and what are the doses you have to use to have minimal efficacy? I mean,
Propofol we can use, sir. Loading dose 1 to 2 mg per kg body weight, followed by 20 mcg per kg per hour, sir. And ketamine we can give, sir, 2 mg per kg loading dose, followed by 1.5 to 1 mg per kg per hour, sir. And thiopental 2 to 7 mg as a loading dose, followed by 0.5 to 5 mg per hour.
Okay. So which you will avoid in which situation? Propofol. We'll start with propofol. When you will avoid? That's what we wanted to know. Like what sir said. When will you avoid propofol infusion?
Hypotension, it can aggravate the hypotension, sir.
Okay.
And it can if we go on high doses,
hours.
5 mg per kg for more than 48 hours, it can cause propofol infusion syndrome, sir.
Okay.
And
4 mg per kg per hour. More than that.
It's more than.
Okay.
Who are more prone?
Children
are more prone.
Pediatric age group.
Lean body mass also. Yeah. Okay. Midas?
Hypertension it can cause. And tachyphylaxis.
Unintubated patients. Respiratory depression.
Yes.
How much you have to use for status epilepticus? We can't use like a sedation dose, no? So how do you start? At what dose? Infusion dose. And if there is a seizure while on infusion, how do you increase?
0.2 mg per kg, we can go up till 10 mg per 10 mg stat. We can surrender infusion 2 mg per kg per hour. Can start.
0.1 mg per kg per hour to 0.1 mg per kg per hour to 0.5 mg per kg per hour. And breakthrough seizures, you have to give at least 1 mg per kg per hour. 0.1 mg per kg per 0.1 mg per kg bolus. Okay. And the other one, ketamine?
1 to 2 mg per kg, you can as a start dose, followed by 1.5 to 1 mg per kg per hour, sir.
1 mg per kg per hour, or 1 to 5 mg per kg per hour, no?
1.5 to 1.
1.5 to 1. More.
5 mg per
5. For breakthrough, you have to give bolus as 1 to 2 mg per kg. And any recent evidence you have looked at for ketamine? How will ketamine act?
Sir, ketamine is a GABA agonist, NMDA antagonist. And
so what is the advantage?
Catecholamine releases, so it can increase the heart rate and cardiac output.
It acts on a different.
No, in seizures, in status, how is it helping?
And
we have all other drugs acting
GABA
either in sodium channel or calcium channel or GABA.
This is action
ketamine is helping.
It acts on a different site than the other anti-epileptics. Others are predominantly targeting GABA receptors. This acts on NMDA receptors, and it is considered relatively safe and ketamine. And recent trials show it doesn't actually increase
in status. As time goes on, there will be internalization of all GABA receptors, and NMDA will take over. So in a little later, I mean, if not for the initial 24 hours, if seizures are still persisting, if you block NMDA, there is high chance that you will get seizure control. So now there are studies studying combination with ketamine even in an earlier time. They have identified few subgroups like seizure plus state, where they say these people have high chances that they don't respond to a benzodiazepine. In such groups, they are studying on where you can combine ketamine with midas or ketamine with other drugs as an infusion to achieve early control of status.
Because ketamine is the exact drug which acts, the only drug which acts on NMDA receptors against. So it's an ideal drug, but till now trials haven't shown much promising. The only reason is it is being probably started too late. That is the reason, probably. That's the reason they are trying to introduce, as Dr. Chaitanya said, they're trying to introduce along with the other anti-epileptic drugs so that you can target this. Okay. Okay, when you are giving propofol, suppose suddenly patient develops jerks. So what could be the possibility? Do you think that patient is having breakthrough seizures? So, I mean, this is a little a question where you should always critical care people should know. Sometimes propofol can cause involuntary movements mimicking like seizures. Propofol, because of, they say multiple mechanisms are there. Of this one, they say that subcortical release phenomenon, a lot of theory is there going on. But when a patient on propofol developing jerks, you have to be careful. See, probably it is not a seizure. It could be a propofol related jerks itself. That is one important thing you have to notice this. Fine.
So now in your patient where you moved from status to refractory status epilepticus, apart from trying to achieve seizure control, we also need to treat your suspected etiologies, awaiting reports. So here, what have you done? Apart from you have discontinued the offending drug.
Yes,
Now you have a differential of autoimmune encephalitis. What did you do for that? Because those reports will take some time. Would you want to wait, or you would have done something at that moment?
Can give IV pulsing steroids, sir. In autoimmune encephalitis, it can first line of choice is IV methylprednisolone pulsing dose, sir. 1 gram per day for 3 to 5 days we can give, sir. If the patient is not responding, then we can give either IVIG or Plex plasma exchange. We can go, sir.
Okay. So which we will prefer? You have both access to both plasma exchange and IVIG. In this patient, what you would have chosen, IVIG or plasma exchange?
IVIG.
Why? I want you to tell 1 or 2 points for and against both IVIG in this patient, for and against, plasma exchange for and against.
Plasma exchange, chance of infection will be more after risk will be
of
more,
bleeding
sir.
and
Okay, that will be for any patient. Here in your patient specifically. Here, advantage is he already has a dialysis access.
Yes, sir.
So you need not secure a new access. You can as well start straight away. But what's the other problem? Here, managing your anti-epileptic drugs will change. There will be a lot of variations in your drug levels. Then you will require therapeutic drug monitoring. Because one, during dialysis, and two, during plasma exchange also, there will be a lot of changes in your drug levels. So in status epilepticus, I think IVIG would take first hand. IVIG in hemodialysis patients, again, volume.
Yes, sir.
So that is the other challenge. And dialysis, ongoing dialysis. Those are the challenges here in your patients. And therapeutic drug monitoring, which commonly used drugs you use therapeutic drug monitoring, and when will you check in these patients? In your patient, if you have to do, when we would have done? Somebody not on dialysis, then you look at trough levels. Here, trough will vary not only with your dose, but after dialysis also. So you will have to check before dialysis and after dialysis just to see flux of drugs. And based on that, you can choose your drug dosing, post-dialysis dosing also. And I see you writing PET CT suggestive of. So what was that finding which is suggestive of autoimmune panel? You did whole body, right?
Yes, sir.
Why?
To rule out other any paraneoplastic also, we can get.
Can we rule out paraneoplastic now that you didn't find any tumor? Many a times, and paraneoplastic encephalitis can precede even before you find a tumor sometimes. These patients should continue to be monitored for developing malignancies. And so what findings here would you look for?
Medial
What is that
temporal
suggesting autoimmune?
Medial temporal enhancement,
Mesial.
hippocampal enhancement.
Yeah.
The mixed
Limbic system, mesial temporal, hypermetabolism or hypometabolism. Some of the features can overlap both. If you find it only in the cortical areas, hypermetabolism or hypometabolism, it can be both. It could be autoimmune also. It could be just secondary circulatory or long continuous seizure activity also. But if your findings are multifocal, then again it would suggest autoimmune encephalitis. And you have chosen, you have sent CSF autoimmune panel. If that has come negative, can you rule out?
No, sir.
Why?
Intracellular antibodies will be present in serum also. So along with
So
that,
what are those common antibodies in the panel you look for? And where you look for what? I mean, CSF
in
and serum.
CSF, NMDA, LGI1, and
GABA A,
GABA.
GABA B.
and
CSF, NMDA, serum,
serum,
LGI and Casper.
Casper.
Yeah. LGI, Casper are predominantly intracellular. You need not find them in CSF sometimes. For NMDA, it is always better if you find them in CSF, means their diagnosis has more validity if they are CSF positive. So you started steroid immunosuppression, you've gone on ketamine also, and if they are not yet controlled, what else you can do?
You can go for either ketogenic diet or electroconvulsive therapy or a vagal nerve stimulation or a deep brain stimulation, sir. Phenobarbital coma.
No, why you want to go up to that? Still, you have some more drugs, no? Biological drugs are there, no?
Yes, sir. Recurrent seizures, we can go with rituximab and cyclophosphamide, sir, for relapse cases. Rituximab 375 mg per meter square, and weekly dose we can give, sir. And cyclophosphamide 600 to 700 mg and monthly once dose.
What other anti-epileptic drugs can be used apart from what we have discussed, no? Valproate, phenytoin,
Perampanel.
Perampanel, yes. Perampanel and still some more drugs which you
Clobazam.
Clobazam is again same class, benzodiazepine. So
Did you read about pathophysiology of super-refractory epilepticus, status epilepticus? Read that one so that you will understand which drug to be given. Because nowadays, tocilizumab is there, anakinra is there, IL-6, and I mean, probably it is too much for you right at this point of time. Read about the mechanism of super-refractory status because that is going to take over in, I mean, so why you are using these tocilizumab or IL-6 inhibitors or these drugs, right? Anakinra, and you will understand. Better read about that one. What is the mechanism of action and okay. So does phenobarbital, last question from my side. I think it's phenobarbital has any effect on immunomodulation, immunity effect? Immunity. Does it depress immunity overall? Yes, it can cause. So whenever a case of sepsis is there, be careful when you are giving phenobarbital because it can cause immunosuppression also it can cause. These are things which are very, very minor, but you should be knowing it. Critical care, they expect you to know more than a neurologist in these aspects. Fine. I think you did well, I think. Yes.
yeah. The other thing you could have used inhaled anesthetic agents.
Yes.
The other thing, some simpler OP drugs like topiramate, gabapentin, all these also could have been considered in refractory status where you are left out with no option. Thank you, sir.
So from the audience, there are two questions, sir. I think one is an answer. The second is what is a burst suppression? I think already Dr. Chaitanya has answered that question. The second is would CSF be sufficient instead of going for a PET scan?
Yeah, this is a complex question. Yeah. So CSF, in fact, what we believe is more of a PET scan nowadays rather than the antibodies because there is so much a spectrum of antibodies are coming and we don't know which antibodies are positive. And every day, I think a lot of antibodies are coming, and still some are expected. So, and if you think the cost-wise, rapidity of diagnosis also, PET scan, of course, in countries like India where PET scan is easily available, lesser cost than in abroad where totally it is insurance dependent. I think PET helps us in lot of cases, especially detecting early autoimmune encephalitis, because the antibodies takes longer time to get, and we don't know, we may be missing some newly yet to be diagnosed antibodies.
Okay, sir. The other question or comment would be, any patient who has been on sedation, if after stopping the sedation, when he doesn't get up, one of the most important differential diagnosis what we consider is either a delirium versus non-convulsive status epilepticus, which has to be kept in the mind when we are not able to explain the coma with whatever we are doing. So with this, I think both of them have done very well. Thank you, Subbaiah sir, for joining despite your busy schedule, and asking questions which are quite relevant from the critical care perspective for the students, which are basics of molecules what we routinely use in our ICU. From everything from basics to what they should be knowing. Thank you, Chaitanya, for from the intensive care perspective, you put across what they are supposed to know. I think with this, I'll conclude the session. Thank you, everyone, for joining.
Thank you, sir.
Thank you. Thank you.
Okay, Dr. Chaitanya, see you.
Sir, thank you very much, sir. Thank you.
See you, Ravi.
Good. I think many of those questions I asked was just for the sake of discussion. This is how everyone would manage, but then we should know the background thoughts also going on when we choose something.
Yes.
Okay, this is only a teaching session, not to test your knowledge, right? Yeah.
Thank you, sir.
Thank you,
Right.
sir.
Thank you. Thank you.
Thank you, sir.